Welcome, everyone, to another episode of Palm Peeps. Today is a particularly exciting episode because we are kicking off a new series of episodes. This is called the Palm Peeps Fellows Case Files. And Monty, I really just can't wait.
Me too, first. And welcome back, everyone. This series is all about highlighting fellows from around the country as well as learning from exceptional cases that they see every day. There's so many great programs out there, and each of them have these amazing fellows, case conferences, and teaching opportunities. Here at Plum Peach, we want to help fellows share these more broadly so that we can all learn from them.
Yeah, absolutely. And I feel like there are so many topics that I really only remember well because there was some specific case presentation that I gave or a co-fellow gave, and we'd love to just sort of share that opportunity. And further, like I remember working so hard on some of these presentations, and I know fellows around the country do it. So we'd love to sort of amplify their work and share it more broadly.
Totally agree, first. And as you said, we have another purpose too. There are so many fellowship programs all over the country and world with such fantastic teachers, and we'd love to connect more people to these programs and expertise. So for each episode of Fellows Case Files, we'll have a fellow in training as well as a fellowship program director. And we hope to bring in a diverse group of trainees, faculty, and cases for you to learn from.
Yeah, this should be really fun. So if you hear this episode and you have a great case, definitely reach out to us on Twitter or email us, and we'll try to get you on the show. But for now, let's get started. So to launch things off, we're welcoming two guests from the University of Maryland Medical Center in Baltimore, Maryland. First, we have Fahid Alghanim. Fahid was a senior pulmonary critical care fellow up until just 11 days ago, and now it's finished and it is an independent practice. He attended medical school at the Lebanese American University of Gilbert and Rosemary Chagoury School of Medicine and completed internal medicine residency at Johns Hopkins Bayview. He has published on topics ranging from lung transplant to patient navigators in the ICU. Welcome to Palm Peeps, Fahid.
Thank you so much for having me. It's so exciting to be here. I love your podcast and I can't wait.
Great. And next we have Dr. Van Holden. Van is an associate professor of medicine at the University of Maryland School of Medicine. She specializes in interventional pulmonology. And in addition to that, Van is the Pulmonary and Critical Care Medicine Fellowship Program Director. For those of you who went to ATS this past year, you may have met Van or seen her work as she helped write the core curriculum and help coordinate the resident boot camp. It's amazing to have you on the show today, Van. Welcome to Plum Peeps.
Thank you so much for having me. It's a pleasure to be here, and I'm excited for this discussion.
Yeah, absolutely. Us too. So, for our disclaimer, just as a reminder, this podcast is not meant for specific medical advice. The views we express today are our own. They don't reflect our opinions or policies of our employers. And the case we have is HIPAA compliant, so some details may have been changed to protect the privacy of our patient.
Awesome, Furf. So let's go ahead and get started and dive into the case. Fahid, it sounds like you have a case that spans many months. Can you go ahead and start with the initial patient presentation?
Absolutely. So this patient was a 26-year-old man who presented initially to his PCP for a month and a half of intermittent dyspnea, cough, and chest tightness. On evaluation, immediately the PCP realized that the patient was hypoxemic. He was satting 83% on room air, and he was wheezing on exam. So the PCP ordered a chest X-ray that showed diffuse, hazy, peribronchial opacities in all lung fields, and then sent the patient to the emergency department. I know this is a little bit of information, but what do you think so far?
Yeah, I mean, I think pretty concerning for a young person to be coming in and saturating 83% on ambient air. That's certainly sending to the ED sounds like the right thing, and my antenna are up. The diffuse infiltrates also certainly matches up with the severity of how it seems to be presenting. But I say the time course does feel a little bit atypical. In general, a young person coming in like this, hypoxemic, I'm thinking infection, I'm thinking maybe ARDS with diffuse infiltrates, but he certainly doesn't seem to meet that criteria for acute that we think about in ARDS. So then I start thinking about some of these more insidious diseases. We've talked about autoimmune and connective tissue diseases and associated ILD or infiltrates and organizing pneumonia. And certainly lymphoma is always up on the differential for a young person for me. And then we've talked about also how exposures and toxins and medications can have an effect like this on the lung. So a young person who is like this presents with infiltrates and smokes cigarettes. This is like, and as a young man, classic palm boards question for eosinophilic pneumonia. And so we'll certainly have to take a big social history. Can you tell us a little bit more about him and the history that we got when he eventually got to the ED?
For sure. So he presented with shortness of breath for a month and a half to 2 months prior to presenting to the PCP. More recently, he's been feeling worse and worse. And he actually mentioned that he couldn't go to the gym anymore. He likes to go to the gym, couldn't do it. He has been experiencing an unproductive cough and chest tightness. Of note, his brother had a recent episode of bronchitis. And so he was concerned that could be an infectious problem that he has. For the review of system, he didn't have any fevers, night sweats, weight loss, or any connective tissue disease type symptoms like Raynaud's, joint pain, rash, or Zika symptoms. His past medical history includes asthma, allergic rhinitis, and migraines, and he has a extensive family history of asthma and multiple siblings. For the medications, he takes naproxen, Excedrin, migraine, and albuterol as needed. He does not smoke cigarettes, but he mentioned that he vaped for the last year. Initially, vaped nicotine products, and then in the last 6 months, he vaped THC-containing products. And he works as a physical therapist and has no significant other exposures. On exam, he was afebrile, normotensive, and had a normal heart rate, but he was hypoxic, and he actually required high-flow nasal cannula, 65% FiO2, and a 40-liter flow rate to be saturating in the low 90s. His physical exam was notable for crackles bilaterally, and besides some eczema on his skin, there was nothing else to note. So, Christina, do you have any thoughts about the differential?
Yeah, and I think that was a lot of great information. And as Ferb said, I'm extremely worried about this patient requiring that much oxygen. I'm kind of without a past medical history. So there's still a lot of questions, and I'd definitely be interested in imaging for the patient. But the history that you provided, I think, helps us some. Like Ferb said, it seems like very acute presentations are lower on the differential, such as ARDS. Additionally, while infection is still possible, we think it'd be more indolent, maybe like an endemic fungal infection or TB or HIV with PJP in the right clinical context. However, the course makes something like pneumococcal pneumonia less likely. You mentioned, Fahid, that he does have a personal and family history of asthma as well as eczema, but asthma alone shouldn't cause the diffuse infiltrates that we're seeing or that you described on his imaging. And, we've talked about aspergillus as well in the context of asthma. So something like that could be considered. But, obviously we're keeping our differential broad at this time. And I think one of the most one of the things that stood out to me the most that you said regarding social history is the vaping. We know e-cigarette or vaping associated lung injury needs to be considered in anyone who vapes, and it's more strongly indicated with patients who vape THC containing products that can contain vitamin E acetate. So this is also high on the differential. And then finally, some of the things that Ferf mentioned, inflammatory or autoimmune lung conditions, specifically eosinophilic pneumonia or new rapidly progressive ILD, could still be possible.
Yeah, Monty, I totally agree with the vaping. I remember in that early 2020 when E Valley was like the biggest pulmonary disease out there, and then COVID swooped in and took its crown. But certainly it was something that came on suddenly. We didn't know much about it, and we've certainly learned more about it in the association with vitamin E and THC products. So I know we're going to get further testing. Van, if you were the attending on the Pulm Consult service, what kind of tests would you want at this point?
Sure. So I think part of the workup would include getting a CBC with differential. In particular, I'll be looking to see if he has peripheral eosinophilia, because this could suggest eosinophilic pneumonia, especially in this patient who has a history and family history of asthma. Peripheral eosinophilia could also be present in E. Valley or endemic fungal infections. As you mentioned, the subacute presentation is unusual for infection unless he's immunocompromised, but he is severely hypoxic. So I'd want to be thorough in making sure to rule out infection. Thus, I would check a viral panel, especially in the setting of the COVID pandemic, sputum cultures, strep pneumonia, Legionella antigen, and HIV. So some people may obtain inflammatory markers or procalcitonin. It may not necessarily be helpful in narrowing down a differential diagnosis. What I would want, though, is the CT of the chest. So I'd want to further characterize these bilateral opacities to see if it meets a pattern from one diagnosis over another. With its vaping history, EVALI could present as ground glass or consolidative opacities like lipoid pneumonia, or he could have a underlying interstitial lung disease, in which case I would want to send a serologic workup.
Yeah, I'm so glad you mentioned like the procalcitonin. I feel like that is a topic for us, waiting for us to cover it, right? Because it's used so often, and how much stock do we put into it? But I think I would definitely send it if my hospital had it for sure.
Van, going back to your diagnostic approach, it's like yes to all of those. We want to send those, as soon as possible. So, can you tell us about some of the diagnostics that happen next with this case?
Yeah, absolutely. So they obtained a CBC. The CBC, there was no peripheral blood eosinophilia. It actually was unremarkable. And his BMP as well was normal. Negative procalcitonin. His urine and strep urine strep and Legionella antigens were negative. His HIV screen was negative. And then they did a small serological workup, including ANA, ANCAS, RF, anti-CCP, complement, CKA, aldolase. That was essentially unremarkable. His CT scan was very, very interesting. So it showed severe bilateral diffuse ground glass opacities through all 5 lobes with superimposed intralobular septal thickening, which was consistent with a pattern called crazy paving.
Yeah, and we're definitely going to post these images so everybody can see them. It's an impressive CT scan to say the least. And we've talked about crazy paving before. We had a radiology rounds. I really love it because it's like one of these great medical findings where the name just makes sense. It looks like a crazy paving pattern. That being said, it can be a little bit non-specific. So, Fahid, could you tell us what were you actually describing when we say crazy paving? Like, what are the radiologists actually seeing? And do any things that it makes you think about or made you think about with this case?
Yeah, so I learned a ton when I saw this patient because it was my first introduction to crazy paving. And so it basically means that you have ground glass opacities and then superimposed inter and intralobular septal thickening. The distribution is mostly diffuse. It doesn't have to be a specific location and doesn't really spare any areas in the lungs. It represents active inflammation occurring in the lung, leading to both alveolar infiltrates, but not complete consolidation, and interstitial edema leading to septal thickening. It's really non-specific, so there's a broad differential, and I like to break it down into categories. I usually use the same differential for most conditions. So we'll start with infectious. For the infectious etiologies, PCP pneumonia could be one of the pneumonia that can cause crazy paving. Mycoplasma pneumonia, COVID itself can also cause crazy paving pattern, and then some mycobacterial disease. Then under autoimmune category, sarcoidosis could be one of them that could cause crazy paving, but also pulmonary hemorrhage syndromes such as Pasteur's disease or anti-GBM disease and Church-Strauss, which is an ANCA-associated vasculitis. Drug-induced is another category. Pembrolizumab have been shown in case reports to cause crazy paving pattern. And so that's another one to consider. Certain cancers like mucinous bronchoalveolar carcinoma, in particular, mucin would be filling the alveolar space, and so it would cause GGOs. And then the cancer itself, with its lipidic growth, could cause thickening of the septa, interlobular and intralobular septa, and therefore you'll have the crazy paving pattern. Environmental and inhalational exposures, such as lipoid pneumonia, like was already mentioned. So exposure to animal, vegetable, or petroleum-based oils can cause crazy paving. And then idiopathic conditions like chronic eosinophilic pneumonia, which was already on our differential, idiopathic interstitial pneumonia, such as NSIP and OP. And then one of the biggest one is pulmonary alveolar proteinosis. And then for miscellaneous, ARDS is one of them, but it doesn't really fit our time course for this patient.
That was an awesome review. And I really liked how you kind of broke it down into those 6 kind of large buckets. So again, for our listeners, we had infectious, autoimmune, drug-induced, neoplastic, environmental, and then idiopathic rounding us out. So thanks again for that, and kind of an easy way to kind of start thinking about this in our head as we're moving forward with the case. And it sounds like a bunch of labs have already been sent, specifically the ones that Van had recommended earlier. And this maybe would lead to a few more serologies or any other testing based on our initial screening. Van, and I feel like at this point in the patient's workup, there's always a question about bronchoscopy. One, if the patient could tolerate it, and two, the utility of doing one. So can you tell us what we would look for bronchoscopy in this type of patient that might help us? And would you ever consider doing a transbronchial biopsy or EBUS in this context, or would you usually just proceed with the BAL?
Good question. So I think Fahid provided a very comprehensive differential diagnosis for this crazy paving pattern. Doing a bronchoscopy in this patient would be very helpful to help evaluate and exclude some of those diagnoses. So first, the BAL could help evaluate for infection. I would send for bronchial cultures, AFB stain culture, fungal stain culture, PCP, PCR, and galactomuting. Secondly, with the BAL, you can see if the return is getting progressively bloodier, which would be concerning for DAH. And if this is the case, you could send the first and the last syringe for cell count and differential. Thirdly, the differential can also help look for eosinophils or lymphocytes. Fourth, with his vaping history, obtaining an oil red stain would be very important to see if it is just P-Valley. Fifth, if the BAL return looks milky, then PAP is considered. And I would send the BAL for cytology and PAS staining to help confirm the diagnosis. So I think you can actually evaluate for a lot of these diagnoses with just the BAL. In regards to your second question about doing a transbronchial biopsy, I would consider the risks and benefits of the procedure, specifically asking, will the findings change management? Particularly in this patient who is already on high flow nasal cannula and would be put at risk of bleeding a pneumothorax biopsy. So I would just start with the BAL in this situation.
That's great. And we've talked about our differential filling processes before, pus, blood, fluid, cells, protein. And I think we nailed all of it with some great pearls like the oil red stain and the PAS stain. If you have specific considerations for lipoid or E-Valley for the oil red or PAP for the PAS stain. You mentioned the safety too. And I think this comes up all the time. It's like, what are we going to do with this patient who's so sick, but we don't know what's going on? So for a patient who isn't intubated, is there a particular amount of oxygen they would be on where you'd feel comfortable doing a bronchoscopy or wouldn't do it? And if you had to do it in a patient who was pretty hypoxemic, what kind of monitoring are you using and where are you getting it done?
Well, that's another very good question. I personally don't have a clear cutoff for oxygen requirement. I think taking into account the patient as a whole and what are the risks and benefits of doing the procedure, how needed are the results. And so in looking at the patient, I would see if they're tachypnic, if they're using accessory muscles or tripoding. Certainly, if there's any signs of impending respiratory failure, I would not do the bronchoscopy. On the other hand, if this patient is breathing comfortably, and as I had mentioned, is on high flow at 65%, 40 liters, I would consider doing a bronchoscopy, especially since this is a young patient and obtaining, a diagnosis that would be very informative. To optimize the safety of it, I would do it in a monitored setting. So a bronchoscopy unit, the operating room, or an ICU, or somewhere where there's emergency airway capabilities. I would discuss with the patient the risks and benefits and also think about my procedure approach. So what can I do to help minimize the risk of him getting worsening hypoxemia? So I mostly focused on providing adequate topical lidocaine, giving small doses of sedation and rocking him with his head up, even sitting up, and using an anterior approach.
Thanks so much, Van. And I think that was, you provided just kind of a handful of so many practical pearls regarding bronchoscopy. So that was amazing. So I want to just come back to our case for a minute to summarize. We have a young man in his mid-20s with asthma and migraines and routinely uses nicotine and THC vape products. who's presenting with 2 months of progressive dyspnea, cough, and chest tightness. He is found to have acute hypoxemic respiratory failure requiring high flow nasal cannula, unremarkable basic screening labs, and a CT scan with a crazy paving pattern. Fahid, what happened next?
So he ended up having a bronchoscopy and a BAL, and the affluent from the BAL was cloudy white. There was a diff, cell count and a diff on the BAL that showed 46% PMNs and 54% lymphs, and no eosinophils. The RVP was positive for rhinovirus, and there was 1,500 colony-forming units per ml of MSSA. Cytology was negative for PAS and GMS stains, and there was no malignant stains done. And then PCP was negative, and he had no oiled red co-stain ordered, unfortunately.
All right, that's super helpful. A lot of the tests that Van talked about, we think the rhinovirus is there. To attribute this whole thing to rhinovirus would be pretty impressive, but we consider it. 1,500 CFUs of MSSA. I'm sure we would treat this patient because he's very sick and he's growing a pathogen that could do this, but that's not that many. We usually think of, 10 to the fourth as a cutoff for VAPS. A little bit more ambiguous what you would do on a non-intubated patient and what that cutoff would be. But again, probably warrant treatment, although I'm not feeling like it's a slam dunk. Certainly sounds like no eosinophilic pneumonia. That milky white, fluid makes me think about infection. Certainly makes me think about pulmonary alveolar proteinosis, although you said the PAS stain was negative. And then, it's too bad there was no oil red stain since E-Valley was something we worried about. So it's still sort of on the differential there for sure.
Definitely, Dave. So the patient was definitely treated for MSSA, but the team also felt the same way you did, that the MSSA doesn't really explain his pulmonary infiltrates, and thought that E-Valley is probably the most likely diagnosis. And really, the diagnosis of E-Valley is more a clinical diagnosis than a diagnosis that requires stains and more labs. It's usually based on a clinical history where vaping happened in the last 90 days. It should exclude lung infections, or the infection is not good enough explanation for the findings, and then absence of other causes. If there's a urine tox screen for THC, then that adds it. And then sometimes we can do BL and vitamin E acetate assays in the BL that could suggest it as well. Based on this, the team decided to give him hydrosteroids, and his oxygen requirement went down and improved to around 2 liters at rest and 4 liters with exertion. He was ultimately discharged on prednisone and PCP prophylaxis with close follow-up.
So the one point I just want to highlight is I love that you mentioned how it's a clinical diagnosis, because we were learning what this was as it went. Like we didn't know about vitamin E acetate at first, and so it's not in any of the diagnostic criteria. And it's great that a patient like this is getting treated, even though there's not a proven diagnosis of it. So I think that's a great point.
Yeah, and I think this has been such an amazing case and things that I've learned already so far. For a patient this young, I know follow-up's going to be important in ensuring that we have something set up for him in close proximity after discharge. So can you tell us how he did after being discharged from the hospital?
Yeah, so this is where the plot thickens or we get involved. So his prior course was all in an affiliated hospital. He was following as an outpatient and had become progressively more dyspneic and more hypoxemic. He had an extensive laboratory workup with negative hypersensitivity pneumonitis panel, myositis panel, and an extensive autoimmune and connective tissue disease workup, which was completely negative. He did have PFTs as an outpatient that showed evidence of moderate restriction and a severe gas transfer defect. He had an echo that was unremarkable. Given his steroid responsiveness, his pulmonologist decided to put him on mycophenolate, and he was even starting a lung transplant workup, and then had a repeat CT chest that showed minimal resolution of the findings, which is somewhat unusual for E-Valley that's being treated.
These are so tough, these cases with the young patients, especially when you're like not exactly sure what they have, because you want to be aggressive, but it's hard to shoot blind. I love that he's undergoing transplant workup. He's a young person, and that's certainly appropriate. We definitely want to figure out what's going on. Van, when you have a case like this, someone who's just not getting better, they're young, you still have just a presumptive diagnosis, but it's not quite fitting. What further things can you try to do to figure out what's driving it all?
Well, at this point, tissue is the issue. So he initially responded to steroids clinically, but now seems to have worsened again. The radiographic findings haven't changed. So now would be when I would consider doing a bronchoscopy with transbronchial biopsy.
Yeah, I love that. And can you walk us through what that looks like, how that's done?
Yeah, so this is typically performed under moderate sedation and with fluoroscopy. The first step is identifying where you want to do the biopsies. So usually you want to target the area that has the most involvement on imaging. This patient has bilateral diffuse opacity, so I would select a lower lobe lateral segment to start with. And this is because if there's any bleeding, it's already in a dependent portion of the lung. And with the lateral segment, it's easier to see on fluoroscopy how far out your forceps is going. So I would wedge the scope in the targeted segment, advance the forceps under fluoroscopy until I meet resistance. This is presumably the pleura. Then I would pull back 2 centimeters and advance the forceps 1 centimeter during exhalation. So that means on the x-ray, I'm looking for the diaphragm to come up. Then I would bite or close the forceps. Now, the hardest part, I think, in the beginning uh, is learning to know when you pull. So this tactile part is important because if you're too proximal and you're biopsying the bronchial airway wall, it's a harder tug. But if you are far out enough, it should just be a slight tug. So I would get at least 5 good samples from at least 2 different segments in that lobe.
An awesome review. And I love the sense of that tactile. I mean, this is why we have someone like you doing these procedures, right? Experience is what drives all of it and knowing how to do it safely and well.
So just to update you on the case, so they had a repeat bronchoscopy with transbronchial biopsies at that time. Again, the cell count and the infectious studies were unrevealing. The lung parenchyma had some alveolar filling with pink amorphous material on histology, and then some hyaline molecules as well as cholesterol clefts. They stained it again for PAS, and at that point, it was positive.
So what's it mean? Put it together for us.
These findings are consistent with pulmonary alveolar proteinosis. The milky white fluid on initial bronchoscopy was certainly consistent with that, and the PS staining on the histology on the histology confirms that.
Wow, that's definitely took a little bit of turn from kind of what I was initially thinking, but such a great case so far. And I think this is a great time to point out how important it is to understand, both the sensitivity as well as the specificity of the tests that we're using. So we definitely learn about PAS testing for pulmonary alveolar proteinosis in residency and throughout fellowship, but the definitive diagnosis is made by seeing PAS positive lipoproteinaceous material in the terminal bronchioles and alveoli on lung biopsy. So in the absence of this, it's often made by BAL positive staining, characteristic imaging findings, as well as eliminating other causes. And in addition, looking for GM CSF antibody testing, which we'll talk about in just a minute. But in a few case series, a diagnosis is made on BAL in up to 60 to 74% of cases, but that still leaves a large amount of folks that may need transbronchial biopsies or even surgical lung biopsies to make the diagnosis.
Yeah, I mean, 60 to 74% is a good amount, but it's not the ton, right? It sounds like we should certainly still have a high suspicion for making the gold standard diagnosis. And in a patient like this, where it sort of fit, but the negative probably threw a lot of people off, it's so important to remember these testing characteristics. Right? Can you tell us a little bit more about pulmonary alveolar proteinosis and how it sort of drives lung disease in a patient like this?
Absolutely. I learned a ton about PAP when I met this patient. So PAP is a disorder of surfactant production. And so surfactant, the physiology of it helps with the surface tension of the alveoli and prevents its collapse. and it's cleared by alveolar macrophages. So if you have a defect in the alveolar macrophage or the surfactant itself, then the surfactant protein would remain in the alveolar space and fill it up and then cause the syndrome. Usually there are three buckets of the disease. One is the congenital bucket, which means that there's a mutation, either surfactant protein itself or in the GM-CSF, which helps bring macrophages to clear surfactants in the lung. And then the second bucket is secondary, which means that it's caused by another condition, sometimes hematological disorders or toxic inhalations, such as vaping, and then some medications. And then the last bucket, which is the most common, is the autoimmune or the primary pulmonary alveolar proteinosis, and it's caused by an antibody against GM-CSF. And therefore, it wouldn't get, the antibodies would chelate this cytokine and then prevents the macrophages from clearing surfactant, and then surfactant accumulates in the alveolar space and causes the syndrome.
That's a great review. And I just had a case just like this too. So I was just kind of reviewing it all myself and going over it. And like you said, the autoimmune PAP is like the main thing we think about. So that GM-CSF antibody, I have to send it off to sort of a specialty lab to run it. And when it comes back, it helps you sort of essentially confirm the diagnosis, even if you didn't have sort of the histologic findings that we do in this case. You know, it's a little bit more common in men than women, and happens in patients in their 30s to 40s. And so sort of having a suspicion, this patient sort of fits the gender demographics and a little younger, although it sounds like you said maybe that there's a secondary thing as well. That being said, he had this positive antibody. So it's always a question, is like, does it trigger it, or is it a combination of these diseases? You know, one really interesting thing about PAP is the treatment. The most widely accepted treatment for moderate to severe disease like this patient has is doing a whole lung lavage, which is just like exceptionally cool to think about and to see. And so, Van, I know that you do this. Could you talk to us about how a whole lung lavage is done?
Yes, I'd be happy to. So, personally, I enjoy cleaning, so I find whole lung lavage personally satisfying. So it's typically performed in the OR under general anesthesia. It can take several hours. The patient is intubated with a double lumen endotracheal tube. So this allows one lung to be ventilated while the other lung is getting lavaged. This also means that the patient has to be able to tolerate single lung ventilation. Then we put the patient in a lateral decubitus position with a targeted lung for lavage up. We instill warm saline using gravity into the targeted lung and then allow it to drain. During the entire time, chest percussion and our best therapy is done. And the goal is to help loosen up all of this proteinaceous fluid to get it out. And we repeat the process until the lavage return is clear. This can take up to 18 liters of fluid sometimes. Our fellows get very proficient in doing chest PT.
Yes. That's right. I mean, 18 liters, unbelievable. Actually, a quick question to that, with the targeted lung for lavage being up, is that just to facilitate clearance of material, or is it so that more blood runs to the ventilated lung and improves the VQ mismatch?
So both. Yep. So we want to perfuse a ventilated lung, which is going to be in a dependent portion. So one important aspect of monitoring during the procedure is to make sure that the lavage fluid isn't going into the ventilated lung.
Yeah, that's awesome. And any role for sort of ECMO support in these patients? I mean, it sounds like you're doing quite a bit in the lungs, and I know we have this sort of extracorporeal option that we could use sometimes.
Yeah, so I think that's a good question, and it probably varies depending on the availability of ECMO. For patients who don't tolerate single lung ventilation, one option is to do serial segmental VAL until the return is clear. So the patient could just be intubated with a regular ET tube. I've done this before, and it's certainly a much longer process, but our fellows become expert VALists by the end.
That's awesome.
Just as a side note, this patient's whole lung lavage took like 8 hours.
Oh my
So imagine doing the segmental VL.
Oh man, wow, that's unbelievable. Does sound satisfying though.
Yeah.
I know. I still can't believe up to 18 liters. Just kind of thinking about it, those listening, I think that's crazy. But definitely happens. And I know y'all shared some incredible photos with us, and we'll definitely make sure that we post those online with the case so that we can get a sense of what was happening. But we know that you cleared the right lung with, close to 18 liters, and the left with about 15 liters. With progressive clearing of the fluid. So probably taking, as you said, the whole 8 hours. Um, in addition to whole lung lavage, though, I'm wondering what other treatments should we be considering for these patients?
There's a lot of interesting treatments that are coming up. So inhaled GM-CSF is a consideration. There's a clinical trial that was published in the New England Journal on a small group of patients that showed that there's improvement in the AA gradient in patients who have been exposed to inhaled GM-CSF over time. Also improvement in their DLCO on the PFTs. And so that's a consideration. There's actually a clinical trial that's still enrolling patients for GM-CSF, and this patient was offered the option to enroll and has been just thinking about it, hasn't decided to do it. The other thing is if you're fit in the autoimmune bucket, immunosuppression could be a possibility, although you have to keep in mind that these patients are more at risk for infectious processes. So giving them immunosuppression while they could potentially harbor an infection that could be dangerous. So sometimes treating infections that you identify first and then doing immunosuppression later could be a consideration. One of the things is doing plasmapheresis to remove the autoantibody, and then rituximab to target CD20 and bring down the B cell that's producing the antibody. In fact, this patient had MAC in his last bronchoscopy during the whole lung lavage, and so just kind of being weary of the fact that sometimes these patients have infections and being making sure you don't give them immunosuppression that could potentially make their infections worse.
That's great. And one follow-up question regarding the MAC. Fahid, did you treat the patient for MAC, or did you just kind of clinically monitor symptoms for him?
Yeah, we did treat the MAC. He didn't follow with us directly. He followed with a affiliated pulmonologist, but they did treat the MAC, and they also put him on immunosuppression as well.
Got it. Okay. Wow. Well, such an amazing case so far. And I think those listening and definitely myself have learned so much about vaping lung injury as well as PAP. And one final question before we wrap up. And this is kind of open to the both of you. Do you think that there was a link between the two?
I personally believe there could potentially be a link between the vaping and the production of autoantibodies, but it's really hard to prove that. Given that there's a secondary category under PAP that includes inhalational exposures, if he didn't have the antibody, then I would say vaping would have directly caused this. But given that he has the antibody, it's really hard to say that. I know like sometimes you have to have an environmental hit before you get an autoimmune process. And so potentially there's a link, and I just can't prove it 100%.
Yeah, makes sense. Sounds very plausible. So how's he doing now? Just to wrap it up.
He's doing much better. He's now off oxygen. He is tapered off prednisone completely and has been maintained on Celsat. As I mentioned before, he was offered enrolling in an inhaled GM-CSF clinical trial, and he's been thinking about it, hasn't decided to do it, has been able to go to the gym more frequently and exercising. His PFTs look better, especially the DLCO. So he's doing good. I'm glad for him. Happy for him.
That's great. Yeah, I was definitely going to ask you because I know you said initially on his PFTs, kind of before treatment for PAP, he had severe gas transfer defects. So I would suspect with him going regularly to the gym, that's definitely improved. But thank you for mentioning that as kind of his follow up. And I think we've had such an incredible opening episode for our Fellows Case File series. And thank you so much, Fahid and Van, for coming on today. Perf and I are honored that we are getting to do this as kind of our initial case in our series. And we're really excited to start building the network with the University of Maryland. And we'd love for each of you to highlight what you love about the University of Maryland Pulmonary and Critical Care Fellowship.
University of Maryland has been awesome. You see the most diverse, sickest patients in the region, especially in the critical care realm. It's also a place that's very supportive, takes care of you, especially during the COVID pandemic. We were allowed to have some time off when we needed it in case someone's having some like emotional issues related to patients that we've been exposed to. It's been an honor to train there, and I feel very well equipped to be out in the community practicing pulmonary and critical care.
Yeah, and for me, the answer is very easy to this question. I love my fellows, including Fahid. They inspire me to be better leaders, better physicians. They are actually my role models, and I could not do this job without their support.
Amazing. And you get to learn how to do great chest PT and whole lung lavage.
Yeah.
So finally, we'd just like to wrap up with a takeaway point. This is a great case, and mine is definitely going to be that the BAL-PAS staining is not always the rule-out test. It's very specific when you find it, but if it's negative, it doesn't mean you definitely don't have PAP. And so you should have a high suspicion and go for transbronchial biopsy or lung biopsy if you need it. Monty, what's your takeaway?
I feel like I have two. I mean, I think just Van provided so much practical knowledge regarding bronchoscopies and transbronchial biopsies. But I really liked Fahed's kind of approach to crazy paving pattern on imaging. And I think we think of PAP a lot with that, but I really like how he brought those 6 buckets in. And again, those were infectious, autoimmune, drug-induced, neoplastic, environmental, as well as idiopathic.
Great. Van, what about you?
Yeah, so I think a good takeaway point would be thinking about all of the tests that you'd want to order on the BAL fluid or even on the biopsies. It's much harder to add certain tests on afterwards. And so being comprehensive up front, kind of reviewing what tests you want to get with with your attendings or even with your colleagues is important.
Great. And Fahid, our fellow Case Files All-Star now.
Thanks. So learning about pulmonary alveolar proteinosis and the 3 major buckets that it fits into and the different treatments. This is kind of my major learning point in this patient.
Love it. Well, thank you both so much for coming on. Thank you all for listening to Pulm Peeps and to our Fellows Case Files series. This episode was written, produced, and edited by myself and Christina Montemayor, and the music is original music by Eric Rogers. See you next time.